my slides up. All right. Can you see my slides? Yep, thanks, Renee. So good morning, everyone. My name is Sara Dugan. I'm a mental health pharmacist and faculty at the Northeast Ohio Medical University College of Pharmacy. And when I was asked to come up with a topic, this is one of the conditions that happened to be a component of the last few cases that we looked at. So I thought it might be a good time to just do a 101 overview of ADHD meds. So my hope is that I'm going to do three things for you today. So list the pharmacologic options. So what are the drug treatments? They're not the only treatment for ADHD, but I'm a pharmacist. We're focused on the drugs, so we're going to focus on the drugs today. I'm going to talk a little bit about how they work. I have some pictures for you. I think it's helpful to provide context. What exactly is it that we're doing to try to help with these symptoms? And then we're going to look at both the efficacy and some of the side effects for these meds. Why did I pick this topic? Well, we had seen it over the last few weeks. It's one of our most common neurodevelopmental disorders in children. ADHD is actually one of the more researched pharmacologic topics in a pediatric and adolescent population. So if we're looking at evidence, we have a lot more evidence for drug treatment for ADHD than we do for a lot of other conditions. And the prevalence tends to be relatively high. It depends on the population that we look at, but the 2016 to 2019 data does suggest that the ADHD prevalence is right around 10%, but it does depend on the population that we're looking at. So for our younger kids, it's about a 2% prevalence, and we see it transition more to that 10 to 13 range once we hit those who are more school age. Focus of treatments today really are going to be those school age kids. So we do have approval down to the age of 3 for some of the medications, but most of the studies and the evidence that we're going to kind of focus on today is more for that 6 and above population. We've got the 3 different subtypes of ADHD with lots of different symptoms. One of the nice things with our pharmacologic treatments for ADHD, we can target quite a few of these symptoms. Symptoms of inattention, of hyperactivity, and impulsivity tend to respond well, at least to our first line medication options. Sometimes we don't have as good of a match of the symptoms of a disorder and what we're able to treat. I'll use psychosis, for example. For patients who have delusions, our antipsychotics don't do a great job of being able to treat them, but we do have a nice match here with the symptoms of ADHD. So all of the treatment options I'm talking about, when a patient starts on them, then we see improvement. We should see improvement in their inattentive symptoms, in those hyperactive or impulsive symptoms. Those would be the things to watch for. Time frame is going to differ, but those would be the symptom improvements to be reporting back on. Since there are a lot of those different symptoms, and one person with ADHD may look very differently than the next person with ADHD, I like to bring this in. There's a lot of variability, not only within what the condition looks like for each of the patients, but also in patients who just have the diagnosis and those that don't. I think one of the common misperceptions, maybe for the lay public, is that folks who have ADHD tend to have intellectual or cognitive deficits. That's not true. They can perform as cognitively well as the controls. They do it differently, though. This was a study that was done at the University of California, Davis, and they looked at patients, controlled teenagers, and they had them perform a handful of tasks while they did imaging, looking at pictures, reading words, potentially some math problems. And then they had individuals who were diagnosed with ADHD. And what they were watching is, as they did these different things, what areas of their brain were they using? What areas lit up? So they were evaluating whether or not there was a difference in how quickly people were responding, how accurately they were responding to some of the questions, and what areas of the brain they were using. And what they found was folks with ADHD used different areas. So as you can see, for whatever the activity was when they took this picture, the teenagers who did not have ADHD were using different parts of their brain, especially in the prefrontal area, whereas folks with ADHD had to kind of compensate with other areas because the areas for the control patients may not have been working quite as well, even if they got the same scores. So we recognize that they're using their brain differently. Do we always have to treat their symptoms? I'm going to argue yes, because there are quite a few complications that can happen if we let folks really struggle with this. Just because they can compensate and use other areas of their brain doesn't mean that that doesn't have a cost associated with it. And we know that for individuals who have been untreated with ADHD, we can see higher accident rates. We can see poor self-esteem, lower educational achievements, not because they can't do it, but maybe it takes them a longer period of time. Maybe there's a level of frustration. Maybe at some point they're just really done with having to put in all of that extra effort. So we're hoping to prevent some of those complications by offering them appropriate treatment. Lots of treatment options. I wanted to include them all because I recognize that drugs aren't the only thing. They're one piece of a treatment plan for a patient with ADHD, but that's what we're going to focus on today. So we've got 3 classes: stimulants, the norepinephrine reuptake inhibitors, and the alpha agonists. These are the 3 main classes of medication that really have the best evidence for treatment. And they fall in that order in terms of how much evidence we have to support their use. So stimulants, methylphenidate or amphetamine, or Ritalin and Adderall preparations, those really are the gold standard. Those tend to be the most effective for our patients. I'm going to argue that our blue and orange boxes are much closer together than they have been in the past. So agents like atomoxetine, your Strattera, and then alpha agonists are clonidine and guanfacine. It used to be very clear that we'd use atomoxetine first and then use those alpha agonists, but that gap has been closing, and they're a little bit more both options in the event that we can't use one of our Ritalin or Adderall options. And it's not just me saying so or saying that the treatment guidelines say so, but when we look at the evidence, the effect size, so how well the medications improve symptoms, it is significantly higher for stimulants, both methylphenidate and the amphetamines, than it is for the other agents. Not that they don't work, they do, they improve the symptoms, but not to the same extent. So if we're looking at options and folks are reluctant to use stimulants for any reason, that's okay. But the reason that we use those first is because they do tend to be more effective. So they're effective. How do they work? Here's our pharmacology. So y'all can take a deep breath and get ready. My pictures, crude as they may be. So this is an example, and this is a generalization. So big picture. So this is a neuron. On the neuron, we have a whole bunch of little locations that have receptors. We have orange norepinephrine receptors, and in this case, green dopamine receptors. They're not actually orange and green, but it helps me keep them clear. Those receptors work with the chemicals, the neurotransmitters, norepinephrine and dopamine, to do a bunch of different things. For dopamine, when it works on some of those receptors, what can happen is wherever you're sitting, take just a moment. Think about everything that you hear. My phone just went off, the fans on my computer, the lights are buzzing, there's people out in the hallway, there's all of this other activity and information that may be going on. For most of us, we're able to filter some of that out. Dopamine seems to help us a little bit with that, taking in the sound of the fan of my computer or the buzz of my phone, which is super annoying, but helping me get rid of that and not pay attention to that, even though it's here. So it almost takes that input, that sensory input information, and is able to filter it out so it's not something that we're focused on. The norepinephrine tends to do just the opposite. So as the information comes in, hopefully my voice is one of the inputs that you're focused on, that you're able to process the information, that maybe it's going into the memory circuits. So this really helps focus the information. They don't only do that, but from a big picture perspective, those are two of the actions that we do see. So norepinephrine focusing and dopamine helping filter out some of that extra information, then we may not be quite as impulsive or need to move around quite as much. We can kind of ignore some of those senses, and that's how we can get control of some of our ADHD symptoms. So how do our meds fit in? Well, stimulants, I told you, tend to be the most effective treatment class that we have. They do both. They help us have more of those chemicals, more norepinephrine, more dopamine, so we can get more filter and more focus. So if we're getting a little bit of extra, that can help get some of those symptoms better under control so folks can take care of what they need to take care of. How do they compare? Are you a Ritalin or an Adderall camp person? They tend to be equally effective. So there's about 40% of patients that can respond to either one. There are about 40% of patients that will only respond to one or the other. It tends to be provider preference. Sometimes there are other characteristics that may lead them to want to use one over the other, but they're equal options. For those math folks that are there, I left my 20% out. Of that 20%, about 15% of folks either partially respond or are unable to really tolerate. They have a lot of side effects from those medications. There's about 5% or less that don't tend to respond to the stimulants at all. And there are some genetic changes that can help us identify some of those folks, but they're not quite as consistent or as strong as we need at this point. So there aren't too many that won't have any response at all to stimulants. One of the good news pieces about the use of stimulants, because they increase dopamine, there is a potential for misuse and abuse. So that is one of the concerns with them, but they work really quickly. So we don't have to have an extended trial. We can give a patient a medication and we should know within hours whether or not that's going to be effective for them. So we really don't need to wait to see an effect. But what we do need to do is, how long do we need an effect for? Do we need symptoms controlled for a long period of time, for a shorter period of time? And the drug company has done the drug industry has done an amazing job of proliferating your options. So these next couple slides are for your information only, so please do not be overwhelmed. There are short-acting options. Here are your brand and generic. They work quickly, and they're only going to work for about 4 to 6 hours. We have some intermediate options. So these may have to be dosed a couple times a day to get control for a full day. They're going to last more 6 to 8 hours. Then we've got longer number 1, which tends to last between 8 and 12 hours. And for the most part, only needs to be dosed once a day. And then longer number 2 is because sometimes 8 to 12 hours wasn't enough, and these options can last for more than 12 hours. For most of the longer acting preparations, we do need to be careful about chewing and crushing unless they're actually a chewable tablet, because we don't want to mess up the formulation that helps deliver medicine over a longer period of time. But if you have a patient that's on medicine, hopefully these can be helpful resources for you to go back and take a peek at. So that's how most of those preparations differ. If you see that there are these huge lists of stimulants, it's really a couple different medications that increase those chemicals, and then they're all formulated different. Everybody wants to make it in their own way to be able to cash in on some of the returns. They aren't without side effects. So our initial side effects, appetite suppression, they're keeping you up and awake and alert, so it tends to cause insomnia. So those real long acting preparations aren't always a good thing. Sometimes we have to go to the shorter ones so that folks can get to sleep. Things like abdominal pain, headache, nervousness, those tend to go away over time. For patients who stay on these medications for a longer period of time, we can see some concerns with appetite suppression. They're just not as hungry. That insomnia, sometimes we got to change our formulation. And there are some concerns about growth velocity. Now, folks with ADHD do have a slower growth velocity than folks that don't have it, but that might be exacerbated a little bit with the use of stimulants. So we do need to keep close tabs on that. And we're increasing dopamine. Dopamine's involved in movement, so sometimes we can see tics. They become much more pronounced when patients are on the stimulant medications, so sometimes we need to do something about that. From a potentially serious standpoint, there are some folks that can develop hallucinations, so more dopamine that also seems to be involved with hallucinations, so we may need to make some adjustments there. And it can increase both blood pressure and heart rate. So we'll want to make sure that we're monitoring, especially in folks that may have some cardiovascular conditions or history. So snapshot of stimulants, they work pretty well, but they do have quite a few adverse effects, but they work quickly. These other two not working quite so fast. So our norepinephrine reuptake inhibitors. So this is the Quellbri and the Strattera. So atomoxetine and viloxazine are the other names. These are going to focus on the norepinephrine. So they're going to keep more of that chemical out and about and able to work on those receptors so we can help control some of the symptoms. These do not work right away. So patients need to keep taking the medicine for 2 to 4 weeks before we start to see an improvement. Sometimes it may take 6 or 8 weeks. If we start on a low dose and we don't see much, sometimes we got to give them a little more to see if it'll actually work for them. Of these two, they can be used on their own. They can be used in combination with other products. And we tend to see them used in adults who have ADHD, just because many of the adults with ADHD may have some substance use concerns where we may not want to go down the stimulant route. So sometimes you'll see it used preferentially in that population. They have their own adverse effects. Increase in the norepinephrine, we still see changes in blood pressure and heart rate. We can see a bunch of gastrointestinal effects. It doesn't just work on norepinephrine. We see a couple other chemicals get involved. So constipation, dry mouth, nausea, vomiting. They also can kind of lose their appetite a little bit, but many of these do tend to improve over time. So as a patient continues to take it, in most cases, they won't continue to be nauseous while they're on it. That'll go away. So, okay, tolerated, doesn't work quite as well as our stimulants, but still effective, but we do have to wait to see an improvement. We're going to hear a similar story with that last class, so our alpha agonist. So this is clonidine guanfacine. So your Catve, your Intuniv, these are actually really old medicines that were used for blood pressure. They also are going to work on norepinephrine. So they are not increasing the amount of norepinephrine, but they're acting like a mimic. So that's why it's a red rectangle that's cut out. That's the medication. So the medication actually works on those receptors to try to provide that same signal. So if we're not just boosting the chemical that's there, maybe we can replace it a little bit and still get that same effect. So that's essentially what these guys are doing. Few different treatment options, again, can be used alone or in combination. One of the nice things with the alpha agonists is that sometimes it can help with side effects. So if a patient develops insomnia or they develop tics, when they're on a stimulant, maybe we use a shorter stimulant and we can add this on board to help control the symptoms and to address some of those side effects that we were seeing with the stimulant. So in some cases, that's what we end up doing to help control the symptoms and better manage things for the patient. We try not to use a drug to treat the side effects of another drug, but if the patient still needs some symptom control, sometimes this can be beneficial. Does not always work quickly. It does take usually a couple weeks You can see improvement in 1 to 2 weeks, but oftentimes we may need to wait about 2 to 4 weeks to see the full effect of how well this is going to work. So for those patients, if they're used to the stimulant where it's like, oh, we'll know that this works right away, nah, we got to stay on this for a little bit, and then we'll check in and see if those symptoms have improved. So 3 very different options. They work somewhat similarly, but very uniquely for each of them. And they all do come with those adverse effects that we need to be mindful of. For our alpha agonists, I mentioned that they had been blood pressure medicines. This would be a class of medicine, especially if patients are on higher doses. We'd rather not have them just abruptly stopping it. So if patients only sometimes want to take their meds, these might be one of the drugs that we kind of want to get rid of, just for safety reasons, because we don't want their blood pressure and heart rate going all over the place. Some of the other adverse effects, constipation, dizziness, dry mouth, they do tend to go away over time. That sedation can stick around, and sometimes that's a good thing for patients. For other patients, that might be really problematic, and we'll need to make some adjustments. So that was a quick drive-by of 3 classes of medicines that we use for ADHD. The meds are a part, but they tend to be a pretty consistent part for a number of kids' treatment plans for ADHD. Most of the meds are going to focus on those 2 chemicals, so dopamine and norepinephrine. And these 3 classes really would be the ones that we would start with for those patients. So with that, I will stop my share